Welcome back to the deep dive.
Mhm.
Really glad you could join us. We're diving into some listener-shared material today, pulling out the core insights.
Yeah, looking forward to it.
Today's topic is one that, well, it pops up everywhere, but it's huge in ophthalmology, ocular pain.
Absolutely fundamental. It's not just discomfort, it's a critical signal. Something every clinician needs to get good at reading fast.
Right. And the material we're looking at, it really frames ocular pain as this key diagnostic piece.
hmm
So our mission today is to unpack that, help you spot the crucial differences.
And figure out if that eye pain is, just an irritation or if it's actually a major red flag for vision loss.
Exactly. We'll kind of work our way through, surface inwards, look at the different causes, the types of pain.
And crucially, the other signs. What else has to be going on to make you think, okay, this is urgent? It's about sorting the benign from the really bad stuff.
Okay, let's dive in. Let's start with a situation, one that should immediately raise some alarms. Imagine someone comes in, they have eye pain, sure.
But it's more than that.
Yeah, their vision is getting blurry and quickly. Light sensitivity is intense. They're tearing up a lot. And even just moving their eye hurts.
Okay, yeah. That cluster of symptoms. Pain, vision loss, photophobia, pain on eye movement. That immediately makes you think of serious possibilities.
Like what specifically?
Well, you're thinking cornea issues, maybe inflammation inside the eye, or even problems deeper, in the orbit itself. Those are definite red flags.
So let's nail down what we actually mean by ocular pain. It's discomfort from the eye, yes, but also.
Right, it can be the tissues around it too, eyelids, the periorbital area, or even deeper in the socket, the orbit.
And the pain itself can feel really different, right?
Oh, completely. It ranges from that mild, gritty feeling like you've got something tiny stuck in there, all the way to, well, agony.
So the challenge is using the pain's characteristics.
Exactly. How bad is it? Did it start suddenly? And critically, what else is happening? Those associated symptoms and signs are key. That's how you start sorting things out.
This is where the material gets super practical. It emphasizes that the pain is just step one. You have to look at the whole picture. Is vision affected?
Right. Is there photophobia, excessive tearing, nausea even? And then, what do you actually see on exam?
Like redness patterns.
Yeah. Is it diffuse or localized? What's the cornea look like? Is it clear or is there haziness, an ulcer? Can you see inflammation inside the eye in the anterior chamber?
And pupils, eye movements.
Crucial. How are the pupils reacting? Is one different? Is the eye bulging out proptosis? Can they move their eyes freely in all directions? And the RAPD, the relative afferent pupillary defect, that tells you about optic nerve function. You put the pain together with all these findings.
Okay, let's follow that systematic approach from the material, starting outside and working in. Where can this pain originate?
Makes sense. Let's start with the eyelids and adnexa, the surrounding structures. Pain here is common, but usually less severe. Think blepharitis.
Lid margin inflammation.
Exactly. The pain is often more like itching, burning, a gritty feeling, maybe some crusting, often worse when they wake up.
Or dry eye. Super common, that unstable tear film.
Yeah, it feels like something's in there, burning sensation. Sometimes, weirdly, they tear up more because the eye's just irritated. But again, usually discomfort, not sharp, severe pain.
What about slightly deeper, the lacrimal system?
Right, dacryocystitis, cystitis, that's the lacrimal sac getting infected, or dacryoadenitis, the gland itself. You get pain, tenderness, swelling right over that area, maybe redness, still usually localized discomfort, though.
Okay, moving on to the surface now. The conjunctiva. Pink eye, basically.
Conjunctivitis, yeah, typically mild pain here, more irritation, itching, scratchiness.
And the key clue.
The key is usually diffuse redness, the whole white part looks pink, and importantly, vision is normal. If someone has significant pain or vision loss with that redness, you need to look deeper than simple conjunctivitis.
Got it. Now the cornea. This is where pain gets serious, right?
Oh, absolutely. The cornea is loaded with nerve endings. Anything touching it, scratching it, inflaming it, it hurts a lot.
Like a corneal abrasion or a foreign body.
Exactly. That sudden, sharp pain, usually lots of tearing, light sensitivity, blurry vision, feels like there's, a rock in there. Fluorescein dye makes the scratch glow under blue light. It's a classic.
Even a tiny scratch hurts like crazy.
Shows you how sensitive it is. Then you have keratitis, inflammation or infection of the cornea. This is often a big deal, vision threatening.
What types should we think about?
Well, bacterial keratitis can come on fast, cause severe pain, and you'll often see an infiltrate like a white spot or an ulcer on the cornea. Acanthamoeba.
The contact lens one.
Often linked to contacts, especially with water exposure like swimming or showering in them. Infamous for pain that's way, way worse than what the cornea might look like initially. Just agonizing pain.
Okay, what else for corneal pain?
Herpetic keratitis from the herpes virus tends to recur. Pain is maybe moderate, sometimes aching, often has that classic branching pattern, the dendrite. Fungal keratitis, maybe after getting poked with a plant bit, pain can vary. And chemical or UV burns.
Or Older's flash.
Right, or sun lamp exposure, extreme burning pain, tearing. And remember that classic delay with UV, it might take 4 or 5 hours after the exposure for the pain to really hit. Bottom line, significant corneal pain needs an urgent look.
So cornea equals surface trouble, often severe pain. Deeper still, sclera and episclera, the white part itself.
Yeah, and here the difference between epistularitis and scleritis is critical. Epistularitis is superficial inflammation.
How did that feel?
Mild discomfort, maybe an ache, you see redness, but it's usually just in one section, a wedge shape. Vision's fine, not really tender to touch, often clears up on its own. Benign.
But scleritis.
Totally different beast. This is deep inflammation of the sclera. The pain is deep, described as boring, like drilling. It can radiate to the jaw, the temple.
And it looks different.
Yeah, the eye is really tender, and the redness has this characteristic purplish, violaceous hue. Scleritis is serious. It can thin the sclera, even cause a hole, and it's often linked to systemic autoimmune diseases, rheumatoid arthritis, lupus, things like that. This needs urgent attention.
Okay, inside the eye now. The anterior segment. Iris, ciliary body.
Right. Inflammation here is anterior uveitis or iritis. Pain is usually a deep ache, can start suddenly or gradually, comes with major light sensitivity, photophobia, and blurry vision.
What are the signs you look for?
Key signs. Ciliary flush that redness right around the edge of the cornea. And when you look at the slit lamp, you see inflammatory cells floating in the fluid, and flare, which is like protein haze.
That tells you there's inflammation inside.
Exactly. Then there's the really scary stuff in here. Endophthalmitis.
Infection inside the eye.
Yeah, often after surgery or an injury. This is severe pain, vision loss happens fast, and you might see a hypopyon that's a layer of pus collecting at the bottom of the anterior chamber. True emergency.
And the other big emergency in the front.
Acute angle closure glaucoma, AACG. Sudden blockage of the eye's drainage system. Pressure skyrockets.
The pain is legendary, right?
Often described as the worst possible eye pain. Agonizing. Patients often see halos around lights, vision plummets, they feel sick, maybe vomit.
And the eye itself.
Classic signs. The anterior chamber looks shallow, the cornea is swollen and cloudy because of the pressure, and the pupil is stuck mid-dilated, doesn't react well to light. You have to get that pressure down immediately.
Okay, moving behind the eyeball now, into the orbit, the socket. Pain feels deeper here.
Yeah, often described as behind the eye. And the absolute critical thing here is sorting out perceptal versus orbital cellulitis.
Perceptal is in front of the barrier.
Right. Infection of the eyelid tissues in front of the orbital septum causes eyelid pain, swelling, redness. But the eye itself is okay.
Orbital cellulitis is behind that barrier.
Exactly. Infection within the orbit often spread from sinuses. This is way more serious. You get severe deep orbital pain, usually a fever, and the critical signs. Vision loss, pain when moving the eyes, proptosis, the eye is literally pushed forward, and maybe a RAPD.
Those are the big warning signs for orbital involvement.
Absolutely. Painful eye movements and proptosis. You need imaging like a CT scan right away, and usually IV antibiotics. This can threaten vision and even spread to the brain.
Any other orbital causes of pain?
Optic neuritis, inflammation of the optic nerve, often linked to MSSA. Pain is common, classically worse with eye movement. Something like 90% of cases report that. Plus, vision loss and often a RAPD.
Okay.
And IOIS, idiopathic orbital inflammatory syndrome. It's inflammation, but not infection. Can cause sudden deep pain, redness, swelling, limited movement. Can look like cellulitis, but it's treated with steroids.
Finally, what about pain felt around the eye, but not actually from the eye structures? Systemic or referred pain?
Right. A really important one, especially in older adults, is giant cell arteritis, GCA.
Temporal arteritis.
Yeah, inflammation of arteries. Can affect the ones supplying the optic nerve. Patients might have headache around the temple or eye, jaw pain when chewing, that's claudication and the big one. Sudden vision loss because the optic nerve isn't getting enough blood. That's AION.
That's an emergency.
Huge emergency. Needs urgent diagnosis, often a biopsy, and high-dose steroids immediately to save vision, especially in the other eye. Inflammatory markers like ESR, CRP can be elevated.
What else refers pain to the eye area?
Trigeminal neuralgia. causes these horrible electric shock-like pains along the nerve's path, which includes around the eye. But the eye exam itself is totally normal.
Headaches.
For sure, migraine cluster headaches can cause throbbing or sharp pain around one eye. Usually comes with other typical headache features, though, like light sensitivity or maybe nasal stuffiness. Sinusitis too, pressure and ache around the orbit, often worse if you lean forward.
And the really common, less scary one.
Yes, asthenopia, eye strain. Not really severe pain, more fatigue, ache, heaviness, burning after doing a lot of close work like staring at a screen.
And the exam is...
Normal. Though you might find they need glasses or have some focusing issue contributing to it, but the eye structures are healthy.
Okay, wow, that's a lot of possibilities. So how do you actually work it up systematically? It clearly starts with the history.
Definitely. Onset. Sudden or gradual. Quality of pain. Sharp, deep, aching, burning. Worse with movement. Associated symptoms. Vision change. Photophobia, tearing, nausea, any risk factors, contacts, recent surgery, trauma, history of autoimmune disease.
Then the exam. You've mentioned a lot of key points.
Absolutely crucial. Visual acuity first, always. Check the pupils, looking hard for that RAPD. Slit lamp exam. Check the cornea with fluorescein for any abrasions or ulcers. Look for those cells and flare in the anterior chamber. Check eye movements in all directions. Measure the pressure, IOP. Look at the fundus, the back of the eye. And if you suspect angle closure, you need gonioscopy to actually see the drainage angle.
And sometimes you need extra tests.
Yeah, depending on what you suspect. Cultures are key for infection, corneal scrape, maybe fluid from inside the eye, culture the contact lens case. Blood tests if you're thinking GCA or autoimmune links. Imaging CT scan is great for bone, sinuses, orbital cellulitis, fractures. MRI is better for soft tissues, optic nerve, inflammation.
And treatment obviously depends entirely on the cause.
Completely. Antibiotics for bacterial keratitis or cellulitis. Antivirals for herpes. Steroids for inflammation like uveitis, scleritis, optic neuritis. But you have to be really careful with steroids if there's any chance of infection.
Right, steroids can make infections worse.
Dramatically worse sometimes. Surgery might be needed urgently, like a laser procedure for angle closure or surgery for endophthalmitis. Sometimes it's just supportive care. Lubricants for dry eye, maybe drops to dilate the pupil and ease pain in uveitis, pain relief meds. But the rule is, if you see those red flags, get them to an ophthalmologist urgently.
Okay, let's distill this down. The high-yield filter, the quick takeaway from the material.
Okay, if the pain is mild, vision is normal, no significant photophobia, no RAPD, the cornea looks clear, no cells or flare inside, you're likely dealing with something benign, dry eye, blepharitis, maybe conjunctivitis, eye strain. Less urgent. But UT, if the pain is severe, especially if it started suddenly and you have any of those red flags, we talked about vision loss, painful eye movements, proptosis, RAPD, an abnormal-looking cornea, ulcer, infiltrate, swelling, or signs of inflammation inside, cells flare, hypopion.
That's an emergency signal.
That signals emergency. Needs urgent evaluation, likely intervention. Think orbital cellulitis, AACG, endophthalmitis, bad keratitis, scleritis, maybe optic neuritis.
And hammer home that orbital versus perceptual difference again.
Right. Painful eye movements, proptosis, vision loss, RAPD, those point strongly to orbital cellulitis. Needs imaging, IV antibiotics now. If it's just eyelid swelling and pain without those orbital signs, it's more likely perceptual. Still needs treatment, but less immediately dire.
So the core message is, ocular pain is a really valuable clue. Pay attention to its character, its onset, and especially what other signs and symptoms come with it.
Exactly. Learning to spot those patterns, the specific combination of pain type and associated findings, is what lets you act fast and appropriately when someone's vision is potentially on the line. It's about recognizing those critical differentiating signs.
That systematic approach, using the pain and the associated signs, is really your best tool here. Keep focusing on those key differences.
Absolutely. Stay focused, keep learning, and apply that framework. It really does make all the difference in protecting vision.
That's a wrap for this deep dive. Thanks for tuning in.